This is going to be an abbreviated version of our Train the Trainer seminar, which generally takes somewhere between 75 and 90 minutes. We provide this Train the Trainer seminar to health profession students and predominantly so far pharmacy students who want to go out and give a more brief version of the training to other students or community groups, and we typically distribute naloxone at those trainings. So this is going to be an update to show you the slide set for the 2018 to 2019 year of the Operation Naloxone Train the Trainer seminar. I have a few live attendees who I'm going to rely on to give me some answers in real time, because I don't think that's going to come through for those who are at a distance. And then I will download the presentation, and other people will view this via a link in the future. So again, appreciate your time, and I think on this title slide, whenever we change this and are starting out a presentation, I like to start by sharing why I why you, the presenter, are interested in the issue. For me personally, I got involved with overdose prevention while I was a resident at the University of Pittsburgh Medical Center in 2013, 2014, right when the fentanyl crisis was really spiking in that region. And as a pharmacist, I usually share that I don't get the opportunity to pop in and save a life immediately. I reduce people's risk for negative things happening related to their medicines, or risk for death over years and decades by ensuring they're on optimal meds. But having the opportunity to hand out 97 doses of naloxone and have 5 patients come back and say, hey, I used the dose you gave me to save my sister or to save my husband. That was a powerful experience to me that made me want to keep moving with this initiative. And so I start the presentation by sharing that on the title slide. Then, for purposes of doing a pre- and post-assessment, we share this link. And students will go in, they will answer some knowledge questions, as well as respond to some questions regarding their perceptions of people who use drugs or might be at risk for a drug overdose. So I give them about 5 minutes to navigate to this survey and complete it. If they haven't finished at about 4 or 5 minutes, I'll just say, hey, go ahead and try to finish quickly. I'm going to start the presentation to put the onus on to finish soon. These are the learning objectives and really the goals after the end of this 50-minute session, 60-minute session. They're going to be able to recall opioid overdose trends in the U.S. since 1999, identify common risk factors for opioid overdose, recognize signs and symptoms of acute overdose, describe the role of naloxone, and hopefully educate the public regarding this issue. They're doing that for the purpose of joining a group of students in Austin predominantly, but it's for the last year also in San Antonio, and growing to include the Houston region, as well as multiple campus regions of Texas A&M. Dr. Alonso's participants, collaborators, who's on the call now. In the first year, just on the University of Texas campus, we trained 127 university students in overdose prevention, distributed about 50 naloxone kits, and we had reports of at least 3 successful overdose reversals of UT Austin students with that medication. And we know, based on national evidence, that overdose reversals are vastly underreported when you just have passive reporting mechanisms. So that was probably more like 15 students whose lives were saved, but we have 3 confirmed. Now I start with a question that is open to students of all levels and all professions, because we may include social work students or first-year pharmacy students who don't have higher-level pharmacology knowledge. So start by asking, what is an opioid? Let me hear from somebody in my live audience here. What do we use opioids for?
Pain management.
Okay, pain management. It usually comes out first. What else? Why else would a person use an opioid? Diarrhea. So they use it to address diarrhea, also to feel good, right? People use opioids for non-medical purposes or to treat medical problems like depression and anxiety, but that's not necessarily a medical indication that we use them for. What's the name of a common opioid?
Oxycodone.
Oxycodone. Give me another one.
Heroin.
Heroin, okay, good. So I want them to both identify prescription and illicit options. And this is also true when we give the same presentation to a lay audience, when our students are presenting it to a community group. And they use the same slide set. That's part of our change this year. So it'll be the same slide set, a little faster with probably a little less detail on some of the slides. Now, this part is kind of infotainment, talking about the history of opioids and getting people interested. So opioids come from the opium poppy. If you are seeing Game of Thrones, you know the term milk of the poppy. This is where it comes from. When you score an opium poppy, a little bit of fluid comes out, it dries up, turns into a brown sticky substance you can smoke called opium. So that was historically the way that you got high or used an opioid medically. Around 1800, which shocks me that this could have happened at that time, but around 1800, the first chemical, medicinal chemical, was synthesized from a plant, and that was morphine synthesized from opium. So that was the primary active ingredient. It was used on battlefields as a surgical anesthetic and as a pain reliever. And over time, people started to notice something called soldier's disease developing in their patients. That was essentially the term back then for physical opioid dependence. And a really smart pharmaceutical company thought, here's an opportunity. We could market an opioid, a related chemical, as a cure for opioid dependence, a replacement for morphine, and we could also pitch it as good for all the same indications people are using morphine for, their diarrhea, their cough, their pain. And that was how, in 1900, people started to receive heroin made by Bayer Pharmaceuticals. And some people actually got free packages of this in the mail. Now, we know how that turned out over the next 50, 100 years, and the bad experience with heroin and morphine led in general to tighter regulation on access to opioids. Despite that tighter regulation, Vicodin was the most prescribed drug in the United States from 2006 to 2013. So you couldn't walk into a pharmacy without seeing a giant bottle of generic hydrocodone acetaminophen on the fast mover shelf within arm's reach of the pharmacist. That did change, and we'll talk a little bit about some of the forces that caused that to change. Now, we'll move through a few graphs that put the opioid epidemic in perspective and show the distinct waves of the crisis. So, as an audience member, you're probably aware that drug overdoses are now the leading cause of injury death in the U.S. They kill more people than car accidents and guns, more people than HIV/AIDS did at the peak of that crisis. And initially, this was driven mostly by prescription opioids, or opioid analgesics. You can see in the graph here that from 2000 to 2008, opioid overdoses due to prescription opioids quadrupled. And that correlated perfectly with a quadrupling in the prescribing rate of opioids due to a philosophy change in treatment of pain within hospitals and clinics, something that you may have heard referred to as pain as the fifth vital sign. Check pain, ask a patient about a pain score every time that you check their blood pressure and their pulse. That led to an increase in treatment to address the numbers that we were hearing, the pain score of 4 or 5 that maybe we otherwise wouldn't have elicited, and it also was correlated with an increase in overdose deaths. Now, that slowed down and maybe even plateaued a bit around 2010 to 2013. Why do you think that might have happened?
Tighter regulations.
Okay, tighter regulations, like what, for example?
Rescheduling of the drug.
Okay. So rescheduling of hydrocodone, that actually happens in 2013, but it happens in response to greater awareness of dangers of prescription opioids. And so correlated with that, I think, is a change in knowledge and prescribing practices. Prescribing of opioids has actually been decreasing in the U.S. since 2010. Additionally, throughout this time, we see the gradual implementation of prescription monitoring programs in more states. So searchable databases to prevent doctor shopping or people going from one emergency room to the next for opioids. And in 2010, oxycodone, or OxyContin specifically, is reformulated into a crush-resistant formulation, which makes it harder to misuse, harder to crush and snort, but still possible to inject. And also may those things together potentially play into an unintended public health consequence. And so I'll reveal the rest of the graph at this point and point out that from 2010 to 2013, heroin overdoses more than triple, and that makes up for any improvement we may have seen in prescription opioid overdose deaths. So people were pushed to an illicit market that was very dangerous, more unstable in its potency than the prescription market. Now, jump forward to 2014, like I mentioned, as a resident, with the rise of fentanyl, and that's going to foretell a little bit about where we're at with the crisis now. We see an increasing role of fentanyl and other ultra-potent opioids we'll call illicitly manufactured fentanyls, and these causing a greater number of overdose deaths in the U.S. This picture, it depicts roughly equivalent doses of heroin, fentanyl, and carfentanil. So I don't know about you, I think heroin's pretty scary. I don't want my family members using it. But if I got the choice of these three, I'm going to go with them using heroin, right? Unfortunately, this non-pharmaceutical fentanyl, powdered fentanyl thought to be coming mostly from China, increasingly is seen as an adulterant in the illicit supply starting around 2013, 2014 in the U.S. And even more potent opioids like carfentanil have also been found. There are at least 10 fentanyl derivatives that have now been seen in the United States. Some of them in heroin, some of them in pressed pills being sold as hydrocodone, some of them in pressed pills being sold as Xanax. So while I prefer to avoid causing hysteria around the issue, I do think accidental exposure to an ultra-potent opioid is a very concerning issue. This is a graph that shows you overdose deaths all the way up into 2016, and you can see these synthetic ultra-potent opioids like fentanyl now account for the majority of all opioid overdose deaths. So what started as a prescription-associated crisis shifted to an illicit crisis, which has shifted into an ultra-potent illicit crisis. It just keeps getting worse. Those of us who consider ourselves harm reduction advocates would say this is a clear consequence of increasing law enforcement and regulatory interventions while not providing the support that people need, like expanded access to buprenorphine and methadone, at least not to the level that was needed. If you want to ship, if you're an international drug dealer, drug distributor, and you want to get opioids across a country's border or move them within the United States, something that's 50 to 100 times more potent than heroin takes up 50 to 100 times less space. So it's a huge advantage. Plus, they are synthetically made. They aren't derived from opium poppies, so there's no growing season. There's no dependency on growers. All right, so we've got the background context. Now I want to know, what does the audience know about an opioid overdose and how it looks? And specifically, I want to try to draw out some of the most unrealistic TV or movie-based things that they've seen. So from a knowledgeable audience, I'm going to ask you to give me some bad answers. What does an opioid overdose look like? What are you going to walk in and see when you find a friend who has overdosed?
Needles.
Okay, needles all over the place. Maybe one still sticking out of their arm. What else?
Passed out with pills all over.
Okay, they're passed out, their pills spilled all over the floor, something that looks sort of like this. Now, most overdoses don't occur instantly. They occur 30 minutes, an hour after the drug is ingested. This might be different and shifting with increasingly potent opioids, but as a general rule, you're not going to find someone with a needle cap and a handful of pills, and that's how you know that it's obvious when you walk in the door. Instead, we're going to be basing this on a number of symptoms. And I want to also differentiate between just being high and being in an emergent, life-threatening situation where you might die. So first, we're going to talk a little bit about some symptoms of acute intoxication. Small pupils are associated with being high on opioids, though that could be mitigated if a person is on a stimulant. So it's not 100% of the time. Slow speech, slow movement. They might be feeling itchy from a histamine release that's caused by opioids. And the key here for acute intoxication is they're at least mildly responsive. So if you see a friend or family member who you think might have overdosed, what are you going to do to try to wake them up or see if they're responsive?
Call their name.
Okay, yell out their name. That's a pretty good one. They don't respond. What are we going to do next?
Maybe shake their shoulder a little bit.
Okay, shake their shoulders. Still nothing. But you want to be really sure. Now, give me some of the bad answers that we want to get from people. What are some things that people might say you should do or might have heard you should do, but we know better?
Put them in a shower.
Okay, stick them in a shower.
Hit them or slap them.
Slap them, punch them in the face. We do not want to do anything that's going to cause permanent physical damage. It's just unnecessary. So you yell, you shake them a little bit. The next thing you can do is a sternal rub. So make a fist. Now take that fist and put it in the center of your chest. Try to push hard and rub it up and down. It's uncomfortable. If you were doing it to somebody else, trust me, you could do it a lot harder. It'd be a lot more uncomfortable, but it's not going to cause any permanent damage. So we want to recommend the sternal rub. Now, this person who's just high, maybe they're pleasant, maybe they just seem a little sleepy. When you give them the sternal rub, they grunt, they moan, they say, "Get away from me," and you know that they don't actually need naloxone. You should keep an eye on them, but there's no need to induce potential opioid withdrawal if they aren't in a life-threatening opioid overdose. Now, symptoms that might differentiate an overdose are slow or shallow breathing. Again, small pupils could be mitigated, but that's usually going to be present. They're not responsive. So you do the sternal rub, nothing happens. If you get farther along in the process, they may have blue or gray lips, hands, and feet from a lack of oxygenation. Opioid overdose kills you by stopping your breathing, so slowly you're not getting the oxygen to your peripheral tissues. And a deep snoring sound. Again, this is pretty late in the process of respiratory depression and overdose. So hopefully you're catching them while we're still seeing things on the left side here. What do you think are some risk factors for opioid overdose? What sort of patient or person is at highest risk?
Chronic pain patients.
Okay, people with chronic pain. So people who take opioids every day for their pain are certainly at higher risk than a person who just gets a short-term prescription for acute pain. That's true. But there is another subgroup of people that's at much higher risk than people with chronic pain.
Elderly.
Older patients, that's another big risk factor if you're on chronic opioids and you're older. Why do you think that is?
They have decreased clearance or maybe not. Also, liver or lung problems.
Okay. So your kidneys and liver maybe aren't working so well to metabolize and excrete the drug. Additionally, if you've got lung disease like asthma or COPD, since we're not able to recover from an opioid overdose due to breathing, that can put you at increased risk. Now, we talked about another specific opioid, Lisa, you mentioned it, that is not utilized typically for chronic pain. What group of people might be using that?
Recreational drug users.
Okay, recreational drug use is definitely your highest risk factor. And when we go out and talk in the community, I think generally we're targeting that group. Though sometimes we want to target people on chronic opioids, the highest individual risk is people with a current or past illicit use of opioids. So a lot of these risk factors are going to focus on people who use illicit opioids. Increasing your dose. That could be prescription or illicit. Whenever you use more, your body may have a tolerance that was set for the dose you were using previously, so that increases your risk. A change in purity. If you suddenly have to buy your heroin from an unknown dealer, then the chance that you might run into a version that has higher or lower potency that is adulterated with fentanyl or another ultra-potent opioid increases. So that destabilization in the supply chain after a drug bust could increase overdose risk for many people. A change in route. So I used to always take my hydrocodones by mouth, but today I'm going to crush it up and snort it. Or I'm going to inject my oxycodone instead of snorting it. That exposes you to a higher dose. Using alone, so if you don't have someone nearby who can rescue you or call 911, then your risk of dying alone is certainly increased. And then mixing substances. So alcohol is the one we definitely want to bring everyone's attention to. But what's a prescription opioid or prescription medication or class of medications that increases risk when combined with opioids?
Benzos.
Benzos, perfect. So Xanax, Valium, and trying to make sure that we use names that people are familiar with. It's also probably worth noting that gabapentin and Lyrica have been associated with increased risk for overdose now. So it's a growing number of medications. And using again after a period of abstinence, and I can't emphasize enough that this is the most important risk factor. If you have recently been in prison or gone through a detoxification program, an addiction treatment center that does not offer evidence-based medications like buprenorphine or methadone, your risk of dying in the month or other whatever period of time afterwards that you might relapse is massively increased. The risk for someone who's just been released from prison of overdosing is 40 times that of the general population. So we should definitely be targeting these groups at a much higher rate. Every detoxification center should be giving out naloxone, and frankly, they should be giving those medications that maintain some level of physical dependence anyway, given the level of evidence supporting them. All right, so we already talked about if you encounter an overdose, you should shake the person's shoulders, shout their name, and do the sternal rub. If you forgot to mention that at this point in the presentation, this is where you can mention it again. What else do we want to remember to do? What are our first steps when we encounter someone and they don't respond to a sternal rub?
Call 911.
Beautiful. Call 911. Because it might not be an opioid overdose. And by the time you go through the various steps to address it, it may be too late if you call 911 at that point to save someone from their spontaneous cardiac arrest. What else do we want to do?
Their breathing.
Okay, assess their breathing. And you can also breathe for them. So it's a lack of oxygen, a lack of breathing that causes an opioid overdose. You can actually keep somebody alive without naloxone just by providing rescue breathing. And other than calling 911, assessing breathing, possibly providing it for them, what else should you do?
Administer naloxone.
Administer naloxone, there we go. That's the one I'm looking for. So it's called Operation Naloxone, right? So we'll get to that in just a second. So this is the algorithm that we teach in our trainings. We go over it briefly. This is not a full workshop. Most people are not basic life support trained. So we want them to know that this is what you do. And they may need to seek additional training, or they may just only feel comfortable using naloxone, but I want them to know that this is the breakdown. So you try to wake them up. You check their airway. You tilt their head back and look down and see if they're choked on anything. At that point, you can provide rescue breathing. You give 2 hard breaths up front and then 1 breath every 5 seconds. If you have naloxone, get it into them as quick as you can. So that M here we'll say is medicine as opposed to a muscular injection, since there are multiple ways we can give naloxone. And then if the first dose doesn't work, we can give a second dose. How long should you wait for the first dose of naloxone to work?
2 to 3 minutes.
2 to 3 minutes. Perfect. So an intravenous dose of naloxone may work even faster, but most of the time we're not training paramedics. People don't know how to get IV access, and they'll just mess it up if they try. So we're going to talk about other approved formulations for layperson administration, which are intramuscular and intranasal. So after about 2 to 3 minutes, if the person is not responsive, if they're not breathing adequately, you can give a second dose. Why do we want to wait? Why do we not give it immediately?
usually responds.
Okay, but why not just give them all the naloxone you got? What could happen? What's the worst case scenario?
So,
Okay, so we don't want to cause undue harm from opioid withdrawal. Though opioid withdrawal is hardly ever life-threatening, it's not life-threatening if you get appropriate medical support in a timely fashion, which they will because you called 911. So I empathize with people who give all the naloxone or multiple doses quickly, though in that scenario, we don't know that the person needed all of those doses. I mentioned that there's this rise of ultra-potent opioids. There's also a lot of people thinking that because I heard that a local person had to get 5 doses of naloxone, that must mean you need massive doses to reverse ultra-potent opioid overdose. And that's simply not the case. So people are administering the naloxone very quickly out of fear, out of concern. I understand that, but it's not something that should be necessary, even with an ultra-potent opioid. And we'll address that in more detail in a later slide. If you have to leave the person, and this is something that we definitely want to talk about with people who are using opioids illicitly, for reasons that will soon become clear, you should always put them in the recovery position. Roll them on their side so that they don't vomit and aspirate, so that they're in a safer position if you have to leave for a minute to go open the door for paramedics, or if you're running away because you're afraid you're going to get prosecuted for using drugs with the person. Regardless, we want you to call 911, so the recovery position is important. All right, so now, especially for a lay audience, this is when we want to make sure they have an understanding of naloxone. In this picture, the blue molecules, those are heroin. And these green lightning bolts, those are opioid receptors in the brain. So opioid receptors are found in many areas of the brain and in other parts of your body, like your gut. Depending on where you activate the opioid receptor, it can exert different effects. So in your gut, if you activate an opioid receptor with a heroin molecule, it attaches there and it causes an effect, then it causes diarrhea at high concentrations in your gut. If it is in certain parts of your brain, it results in dulling your experience of pain or in causing you to feel tired or confused potentially at high doses. But if you attach those at very high concentrations to opioid receptors on the brainstem, it can shut down your intrinsic drive to breathe. So normally we breathe without even thinking about it. But there are these opioid receptors on the brainstem that, when activated, turn off that process. At modest concentrations, it'll start to slow down. Eventually, breathing will stop completely. If you catch a person when their breathing is inadequate or they've recently stopped breathing, but their heart's still beating, you can give them naloxone, either by an injection into their muscle or a squirt into their nose. And after 2 to 3 minutes, that naloxone molecule, this green bubble, it's going to find its way to that receptor. And it fits better on the receptor. The receptor would rather attach to naloxone. So when it gets in there, it manages to displace the heroin. It attaches to more of the receptors than does the heroin. But naloxone is not an activator. It's not what we call an opioid agonist. So when it attaches, it doesn't cause any effect. It's an opioid antagonist or opioid blocker, meaning it attaches, it sits on the receptor, it prevents heroin from binding, but it doesn't do anything. It doesn't cause pain relief. It doesn't cause a respiratory depression or slowing of breathing. It also doesn't cause pain or increase your respiratory rate, unless you have a physical dependence on opioids. If you have developed a physical dependence because you use either prescription or illicit opioids on a daily basis, then administering naloxone can be a pretty uncomfortable experience. It can push you into acute opioid withdrawal, which, as I mentioned before, is better than not breathing, better than dying, but not something that's a positive experience. This is why people who use opioids, they don't want to overdose. They don't want to have to receive naloxone. They're not looking at naloxone as a backstop, as a safety net to use more than ever, because it's a terrible experience to have your overdose reversed with naloxone. Additionally, When you save someone's life by administering naloxone, you should know that they might not jump up and give you a hug. Their first impulse when they feel sick, when they feel scared, when they're waking up in a place that they may not remember how they got there, surrounded by people, often in uniforms, is not going to be one of excitement and thanks. So just know that. Try to encourage the person to go to the hospital or engage with medical care, though sometimes when people have been using illicit opioids, their fear of prosecution may deter them from doing that. Importantly, naloxone, we're going to say as a general rule, only lasts in your body for 30 to 90 minutes, or about an hour. With really high dose versions, it might still be effective for longer, but given the variable access to different versions, we're going to just keep that as a general rule and say about an hour. Why is that important?
We don't know how much how much the opioid they may put in their system, and so if they have enough of it, then the effects of naloxone can wear off, and then the opioid can just go back to sitting on that receptor.
Perfect. So most opioids are going to last longer than 60 minutes in your body. Some of them, like methadone, could last for multiple days. So a single administration of naloxone that might wear off in an hour is not going to be sufficient. It's another reason why people need emergency medical services and potentially longer observation. I describe naloxone to people as a fire extinguisher. How many of you have a fire extinguisher at home? And keep your hand raised if you've had to use it. Okay, so why do you have it?
Prevention.
Just in case, right? If your house is really important to you, your life is really important to you, you should have naloxone around if you use opioids, regardless of whether that's prescription or illicit use. I encourage people to have one around if you have a teenager, a kid, because you don't know what people are using. Exposure could be accidental. I think it's an important household item. Now, needle exchanges, groups that serve people who use drugs illicitly, have been given out naloxone for decades. But the idea of getting that through a medical provider is a relatively newer concept. However, based on the success of those needle exchanges, all 50 U.S. states and the District of Columbia have passed some form of naloxone access law. They tend to include these three core components. The first, standing orders, allow a pharmacist to dispense naloxone without a prescription. Now, that's not necessarily true. We have to issue a prescription, but basically it's an agreement where a prescriber, usually a physician, signs a document that says this pharmacist or this group of pharmacists can prescribe naloxone at their discretion and use my name to prescribe it. Some states have issued statewide standing orders where any pharmacist can log on online, print off the standing order, tack it on the wall, and start giving out naloxone. Texas has not done that, but most chain pharmacies in Texas do have a standing order in place. The Texas Pharmacy Association makes one available to independents at a fee. Third-party prescribing means that the person who obtains naloxone, whether through a prescriber or at a pharmacy under a standing order, they don't have to be the person at risk for overdose. So if I'm worried about my little brother overdosing, I could go to the 40 Acres Pharmacy here on campus and say, I would like to obtain naloxone. They have a standing order in place, so the pharmacist can basically issue a prescription under that standing order, and they can give me that naloxone or sell it to me, and they can also charge it to my insurance. Finally, these laws provide broad liability protection. So a lot of prescribers, pharmacists are worried if I give someone naloxone, but they administer it wrong in an overdose, or somebody thinks that they used more opioids than ever before just because I gave them naloxone, could I be sued? And these laws give you explicit protection from any such liability. Additionally, anyone who might administer naloxone is similarly protected, even as long as they tried. The statement is administering it in good faith. So you're broadly protected. What our Texas law does include those core components I mentioned. It does not include legal protection for victims or others who are using drugs. So sometimes these are referred to as overdose Good Samaritan laws. So let's say that Lisa and I, Lisa is the student director of Operation Naloxone here with me in the room. Lisa and I are using oxycodone together, and we decide we're going to inject tonight instead of snorting. So after about 30 minutes, I look over, and Lisa's slumped over, and I shake her shoulders. She's not responding. I give her a quick sternal rub, nothing. If I call 911 and police arrive on the scene in Texas, I am not protected from prosecution, even though I was trying to save her life. Lisa is not protected from prosecution, even though she could die if we don't look for help. Some states have passed these laws to provide protection in that scenario, though there are always loopholes. So we're working on it. I would encourage anyone watching this, we should advocate for that change, but it's imperfect. Without having that, we know that many of the people we train are not going to call 911. If they do, they're not going to stay with the victim. So we want to prepare them for all scenarios, which is one of the arguments for giving a higher dose of naloxone that might stay in the system a little bit longer, and for talking about the recovery position. Now, I'd next like to orient people very briefly to the different formulations of naloxone, and since we're usually distributing at least one of them, we can spend most of our time talking about that one version. There's a YouTube video at operationnaloxone.org under the Administer Naloxone tab that shows how to administer every one of these versions, and a couple of others that aren't actually recommended for laypersons anymore. Now, we're going to progress from cheapest and lowest dose to most expensive and highest dose, though they also get generally easier to use as we progress. So vial and syringe, this is the cheapest option. No version has saved more lives than the good old vial and intramuscular syringe. A lot of people feel antsy about this. You're giving a syringe to people who use drugs. Well, that's another discussion, and I disagree with their whole premise. But regardless, an intramuscular needle is huge and long. And if you are a person who injects drugs into your veins, you know that is going to destroy your vein. That is not something anybody wants to use to inject a drug intravenously. So that's not a real concern. There are other concerns, like you might not have the syringe around when you need it because you got to keep the two things together. And some people are concerned about the low dose of this version of naloxone. Like we talked about before, it's going to be sufficient, but it might not last as long. This does require the most training. I don't know about you. My mom finds my little brother slumped over on the floor, and she's got to figure out how to draw up 1 milliliter of fluid out of a vial that could hold 5 milliliters of fluid. I don't have a lot of confidence that that fluid is going to get into my brother's muscle. I worry that she's going to draw up air, she's going to push out the fluid. Something could definitely go wrong. So there are downsides. It requires more training. And that is one of the reasons why the pre-filled syringe with a mucosal atomization device, a little nasal adapter here, gained a lot of popularity in the last 10 years. You can take this version that some of you as healthcare professionals might have seen in crash carts in a hospital, and instead of putting a needle on the end, you can put this atomization device, this nasal adapter on the end. It achieves a slightly higher blood level. You give half of it in one nostril, half in the other, and you'll get more naloxone in your body than with the intramuscular vial and syringe. It's probably a little easier to use. You don't have to draw anything up. You just pop the caps off and click it together. But as we've discovered in trainings, you can break the glass on the vial, the part that contains the medication. So there are definitely mistakes that can be made. Also, the fact that there's a relatively large volume of fluid here, 2 mLs, makes it necessary to use the atomization device and squirt half in each nostril. There are certainly incidents, reports of people being successfully revived by all of this in one nostril without an atomization device, but we should try to give it to people when we can, based on studies of the amount of naloxone that gets into your body. Now, before I give you the next two slides, I want to give a quick disclaimer that Operation Naloxone has benefited from some free medication provided by these drug companies. So I'm going to bring a critical eye and explain the role of these drugs. I tend to really like one and not be such a big fan of the other, and I like to think that that's an impartial viewpoint, but it might not be, so I want you to know. The first is Narcan nasal spray. The cost is jumping up significantly here. So whereas a kit of 2 doses would cost you about $20 for the vials, about $40 for the pre-filled syringe, it's going to cost you $150 without insurance for the Narcan nasal spray. It achieves very high blood levels, though. 3 hours after administration, you've got more naloxone in your body than you did at the peak of a 0.4 milligram IM dose. And it really requires no training. You open up the foil, you pop it in their nose, you squirt it, and you're done. It has a very small amount of fluid, very high concentration, so you don't have to worry about it draining out of the nasal cavity before it's absorbed. And finally, we've got the Evzio auto-injector. So if you're familiar with AviQ, which is an epinephrine auto-injector, this is the same technology but with naloxone in it. It's a little cartridge, you pop it open, and it starts talking to you. It will actually tell you exactly what to do, step by step, to respond to an overdose. But it's pretty expensive. So at this point, I like to have the audience guess $20, $40, $150. Those are the other prices. What do you think a box of 2 of these costs?
$700.
Okay, and then you'll hear something, $700, $900. Just mess with people, tell them to keep going. And the last time I checked, the list price for 2 Evzio auto-injectors was over $4,000. Now, that gets a shock in the crowd, and at this point, you should point out, nobody's probably ever paid that. I don't understand why that's the list price, but I think it is symbolic and representative of the fact that Evzio is often not covered by insurance. For my personal insurance, I checked and it would require a prior authorization. The only thing I can think of in my mind is maybe for a blind person. Are there any reasons why maybe a cartridge that talks to you would not be ideal in Texas? Perfect. So the person your patient, the person you're giving the naloxone to, is not going to administer naloxone to themselves. So the fact that your patient speaks English doesn't mean that the person who responds to their overdose does. And so that's definitely something we should keep in mind. And to me, it's a significant drawback here in addition to cost. But it's very easy to use. And now it only comes in a 2 milligram version, which when administered intramuscularly achieves a higher dose of naloxone in the body or a higher level than even the Narcan nasal spray. So those are your 4 versions that we generally recommend for layperson administration. Again, you can go through that really quickly or even just talk about the one that you're giving out that day in a public training. At this point, we've been going for about 45 minutes. The trainings for students who are going to go out and give this training to the public take about 90 minutes, maybe a little bit less, but we want the slide set to only take about 30 minutes up to this point in the public. So the public is not going to take the quiz on the first page. That's historically we've only done that for the students who are getting training or the follow-up quiz at the end. So where I got in 45 minutes, I think it's reasonable a student might get there in 30, going into a little bit less detail on some things. Now at this point, we break out into groups and go over the case scenarios. This gives other students, not just the 1 or 2 who provided that presentation, but other, especially earlier students, the opportunity to lead a breakout group. They go through 2 case scenarios, which if you have those available to you, you can pause right now and go look at those. And then they go through the answers in their little pods. And I'll just go through the answers quickly with you here. So in the first case, walk into your apartment, look up from your phone to find your 20-year-old roommate passed on the living room floor. What signs and symptoms would indicate an overdose? He doesn't respond to a sternal rub. What should you do before administering naloxone? You administer naloxone. What should you do next? What will happen when you administer naloxone if it was not an opioid overdose? You'll see that both of these cases are just reinforcing content that we already covered in the presentation. Sometimes people forget to include things in the presentation. So this will bring it up, and once these little pods have gone through the case for about 20 minutes, we all come back together at the end to clarify anything that was missed, talk about unclear things from the case, and get additional questions from the people in the audience. And I'll skip through the second case for time. Additionally, I provide some frequently asked questions that I think, and based on our experience, we might encounter when our trainees go out and provide this talk in the community. So we've got some preset. Before you go through them at a community student-led training, you might just let the audience ask a few questions, but we want to make sure that these are hit. So can I administer expired naloxone? What do you guys think?
Yeah.
Okay, perfect. So a lot of people have misconceptions about expired medication. Yes, it's going to be less potent potentially. That's very rarely is that important, especially when we've got a life-threatening situation and this is an emergency reversal medication. For the health profession students in the audience, it's worth noting that tetracycline is the one medication where you really need to be worried about a toxic breakdown product. Otherwise, we're just talking less potent. What if I administer too much naloxone? What's the worst thing that could happen? Withdrawal. And I recently stole this graphic as a quick reminder to people. I don't know how I feel about it. It kind of makes you laugh at the person in the beanie who looks grotesque. So maybe that's not a great one for the public, but it reminds you of some of the symptoms of opioid withdrawal. And personally, reminds me of why a person who uses opioids doesn't want to overdose and isn't going to just use naloxone as a safety net. Along those lines, will naloxone enable drug users to chase higher highs?
No.
We have no evidence to say that that happens. We have a lot of evidence showing that when you increase naloxone access in the community, overdose rates go down. So based on that, we should err on the side of giving people a life-saving medication. The idea that people are taking over naloxone to the heroin party is a myth. And additionally, there's probably nowhere more important in the world to have a big box of naloxone than at a heroin party. So I would encourage us to distribute it widely. Where can I obtain naloxone? People in the audience, maybe we're not distributing naloxone that day or we run out. Where can they go?
Pharmacy.
Okay, a pharmacy, a community pharmacy. Any community pharmacy?
That have a standing order.
Ones that have a standing order, and a group of us have conducted a study recently in Texas and shown even among those that have a standing order, many don't have it in stock or aren't prepared to dispense it. Some pharmacists personally aren't willing or aren't aware yet of this ability or have some misconceptions. So we recommend people call the pharmacy before going. You may have to call a few, but you should be able to get it directly from a pharmacy, or you can ask a prescriber. Community harm reduction groups, like here in Austin, the Austin Harm Reduction Coalition, also have it to pass out. Now here are a couple of new ones based on some emerging issues in public media. Can I overdose just by touching fentanyl powder? Let's say my brother, I'm picking on him, he has snorted fentanyl, he somehow has ended up with a big old clump of it on his face. If I try to brush that off and give him some rescue breathing, can I overdose from touching the fentanyl? No, that's a ridiculous notion. Working as an intern in a hospital, we used to baggie up these little ampules of fentanyl to put in the operating room. It was very common that we would break one or two. I've had fentanyl liquid on my hand. People who compound have sometimes had fentanyl powder on them. We know that that is ludicrous. If you take a fentanyl patch, which was formulated specifically for transdermal application, and you stick it on your body, it takes 6 to 24 hours to really even feel a significant effect from the patch. So flicking a speck of fentanyl powder off your shirt, it ain't going to do it. There have been well-publicized series of police officer reports of experiencing overdose from passive fentanyl exposure. The first one talked about flicking a speck of powder off their shirt and overdosing 30 minutes later. I don't want to say anybody's lying, but if there was a scenario that sounded like maybe they stole it from the drug bust and used it later, that's probably one. There are some other scenarios that are much more understandable, where a first responder has come onto a scene, they come in contact at some point with an unidentified substance, and they start to feel anxious. They start to feel sick and nauseous. They are, their heart's beating out of their chest. Those are physiologic symptoms of severe psychological stress. If I had touched a drug that I thought could come through my skin and kill me instantly, I would freak out too. So I don't blame people for having that response, but it's a lot more similar to some people's automatic response to seeing their own blood than it is an opioid overdose. There are currently zero confirmed scenarios in which a first responder has experienced opioid overdose symptoms from passive exposure to fentanyl. In every instance, it's a big headline that many people or one responder was exposed to fentanyl and treated with naloxone. In none of those incidents have they ever provided any toxicology showing that they actually had an opioid in their system, and multiple toxicologists have written public and medical articles to dispel this myth. This is one example from Slate by Dr. Faust that does a great job of explaining it. He's an emergency room physician and has some input from toxicologists as well. Is fentanyl or other ultra-potent opioids, are they so potent that if you give naloxone, they need higher doses or it won't work at all? Now, I already said that, right? But it's important to note that the American College of Medical Toxicology and American Academy of Clinical Toxicology, the two orgs that are the experts on this issue, have stated that animal data suggests standard doses of naloxone are sufficient even to reverse the most potent fentanyl derivative carfentanil. There's no reason to believe that you can be harmed by passive exposure to fentanyl, or that a typical old 0.4 milligram IM from the vial isn't going to be sufficient. And you got a second vial there just in case, right? So finally, we want to tell people if they want to learn more about naloxone, they can go to our website, operationnaloxone.org. A lot of the resources there are directed toward healthcare professionals. We've got a 2.5-hour continuing education course for prescribers, pharmacists, and social workers, and we're working on more courses and other information for patients. If we're doing a student training, we'll have you do the post-assessment here. If you're just watching this video, maybe on double speed as a retraining, no need to take the pre or post-assessment. But these are linked inside the slide set that any naloxone or trainers who are at other sites can utilize when you train health profession students, so that we can collaborate on that research regarding their pre-post knowledge and attitudes. And we also provide a follow-up survey approximately 3 months later to see if those have been changed based on whether or not they engaged in outreach events. Now, we want to let people know at the Train the Trainer seminar that they will now be, they are now certified, they're now qualified to volunteer at these training events out in the community. Some of them, like you see in the bottom left corner here, are tabling events. International Overdose Awareness Day, where we went to the Capitol and our students taught people about naloxone and gave it out. Or they might look like these other pictures where we go to classrooms or to off-campus student housing cooperatives or other recovery-oriented groups, and we provide this 30-minute naloxone training with 30 minutes of cases and the summary at the end of their to address frequently asked questions. And that's it. So thank you for taking the time to watch the recording or to be here in person. This is your primer for providing the Operation Naloxone Train the Trainer seminar to healthcare students, or as a student who's going to go out and give a shorter version of this presentation in the community. Thanks for your time.